kind. It's really good to be here again. Thank you, Jane, for the invitation. I'm going to talk to you about the European H2020 project that targets weight loss maintenance. I'm working at University College of London at the moment, but this is a project that I did as part of my research associate position in University of Lisbon, and I'm still collaborating in this project. This is a European project that brings together experts from academia, industry, policy, software development companies, and statistical companies to try to deal with a big problem that we have nowadays, which is how can we promote sustainable and long-term weight management. So we have a lot of products and we have a lot of solutions for weight loss, but we know from research that most people that lose weight successfully regain their weight within the next year since they lost the weight before. And usually they regain to the same weight as they had before they lost weight, or even gain more weight. So the idea of this project was to try to develop digital tools and digital solutions to help on weight loss maintenance. And one of the key reasons why we thought that developing digital interventions would be appropriate for this population is because we are talking about people that already tried different solutions, already went through different programs to lose weight, and they need a solution that they can have access to when they are available, when they are struggling, when they need some kind of support in the long term. And it's really difficult to have a face-to-face intervention to help with that when we are talking about some people that need to go through different self-regulation strategies for 5, 10, 15, 20 years, depending on the situation. So what we know from research, and I'm not going to explore this a lot because we have talked about this during the entire day, but we know from research that developing interventions that are based on behavior change theories and techniques that are effective or at least promising is better than developing apps or interventions that don't have a theoretical base, and you saw a few examples. So what we developed in know-how was based on various research conducted by our own team and other teams involved in the project related with long-term weight management. The know-how trial, which I'm going to explain next, is a full factorial design trial that compares only self-monitoring. So users have access to a Fitbit, an activity tracker like this. I'm going to explain better after. And they have access to a Fitbit ARIA scale. And one of the groups only receives self-monitoring features and instructions within a web app that I'm going to show after. Another group receives the self-monitoring strategies plus the emotional regulation component. So they have access to various sessions, online sessions, I'm going to talk about that later, just targeting stress and emotional regulation using various models for emotion regulation. Another group has access to the self-monitoring and then to motivation and a self-regulation component. And motivation in the know-how project is based on self-determination theory. And the other group has access to all of the content. So self-monitoring, motivation, self-regulation, and emotion regulation. And the hypothesis is that the group that has a combination of all the content is the group that will going to have better results in terms of weight management. One of the key things in know-how is that we are not only testing how different contents and how different theory-based techniques work in practice and comparing them, but we are also trying to look at solutions that can be sustainable. So one of the key issues in this consortium that we tried to seek from the beginning was to have links to the private sector. So we have links to the software development teams. In this case, the company that works with us is also a research-focused software development company, which is really useful when we're talking about a research project, but also links with Fitbit and links with Qualtrics for the questionnaires development, which are also part of our toolkit. And at the same time, the dissemination capabilities. So the European Association for the Study of Obesity is one of the partners in this project, which means that we can translate what we will learn from the know-how to policies that can be applied within Europe, and also disseminate in the various forms of communication that EASO has access to. And finally, Slimming World is also a partner in our project. I think that probably a lot of you know what Slimming World is, but it's the most recognized weight loss company in the UK. And they have a lot of online and group-based solutions for weight loss, but there isn't any kind of product for weight loss maintenance. So the idea here is the content of the know-how toolkit that proves to be effectively will be adapted to the Slimming World. So it won't be the same, but will be adapted to the Slimming World product and philosophy and characteristics. So the toolkit that we are developing is going to be tested or is already undergoing the trial on a 6-month intervention with a follow-up of 12 and 18 months. And we are testing it in 1,600 adults in 3 countries, UK, Portugal, and Denmark. And although this sample size may not seem that large, if we consider that we're just talking about weight loss maintenance, so the inclusion criteria is very strict, this is a very large sample size and really difficult in terms of recruitment. Outcomes are changes in body weight, body composition, several biomarkers, and then of course, as secondary outcomes, we are looking at changes in physical activity, diet, sleep, well-being, and all the theoretical mediators that we are testing in know-how. Sorry. This is a blank slide because I had some technical issues with my presentation, so you'll just have to trust that I'm saying the correct thing here. So as I said, our toolkit is based on most promising theories and techniques that are already being used for long-term weight management, but research is still very limited in weight loss maintenance. There are only 2 or 3 trials using digital tools. There are very few trials that are face-to-face, just looking at weight loss maintenance. So as part of the Know-How project, we started by building evidence foundation. So we started by conducting a survey in the 3 countries that we were going to do the trial, so Portugal, Denmark, and the UK, with 2,000 adults that lost weight with success in Europe, asking several questions related with the strategies used to lose weight, the barriers, the needs that these users have, and we also conducted in-depth interviews in the different countries, just looking at emotion regulation, regulation skills, motivation, and other aspects regarding their process of weight loss maintenance. So building on what we know from previous evidence, we also developed evidence foundation as part of know-how to be sure that we were developing something that would be effective and that would be useful for users. Apart from that, we also did a systematic review trying to identify which behavior change techniques and which modes of delivery are most used in digital interventions for weight management. So in any stage of weight loss, weight regain prevention, weight maintenance, what is used. And from the systematic review, unfortunately, we couldn't draw any consistent conclusions because most studies are not very good in reporting the techniques that they use and very, very rarely make a link between the mechanism of action they are targeting, the technique that they select, and the mode of delivery that they use for that. So the links that we wanted to understand, we couldn't get it from the systematic review. And this is what was in this blank slide. So using current guidelines that we have to develop complex interventions for behavior change, we designed the know-how toolkit. So the first thing we did was to select the target behaviors that we were going to address in know-how, and mainly these are physical activity, diet, and also sleep. We then identified the key mechanisms of action that were relevant, and this was based on theory and the evidence foundation that I just mentioned. And these 2 aspects were key to develop the logic models according to the Medical Research Council guidelines. We then selected the behavior change techniques that would have impact for each of the mechanisms of action. And then we translated each technique into the toolkit principles and implementation. So each technique had to be translated in a video, a questionnaire, part of a text, a testimonial, anything that would represent a translation of goal setting, for example, to the toolkit. This is just an example of the logic model of ARM4. So what you have on the left side is the principle, the general principle of the toolkit, the intervention content, the key mediators, and then the outcomes. And each of the boxes for the intervention content are then described in other boxes with all the information, and then how the contextual factors will affect that. And this is the models that we will use for the analysis that we are going to conduct once the trial is finished. And then from this, we develop the principles, and this is just an example. For each implementation, for each part of each session that we have online, we did this pathway that you see here. So we identified the key construct, intervention technique, the rationale, why we were selecting this intervention technique for that mechanism of action, and then how this would be translated to the toolkit. This is what I explained. And we have about 6, 7 modules. Let me just go a bit further so that I don't say it wrong. So we have about 7, 8 modules for ARM, and we have about 16, 18 ARMs, about 140 activities, which means that we did about 140 tables like that for each of the purposes of the toolkit. So going back, so what you see here is when you enter the web app, you have access to several tiles related with the self-monitoring that I will explain next, and then you have a map, and that map shows the content of the toolkit according to the ARM, so emotion regulation or motivation plus self-regulation skills, or emotion regulation and motivational self-regulation skills, and you just select one of the sessions. All the content is available from the beginning, but there is a weekly email that is sent as a prompt saying, this week we suggest that you have access, that you go to this session and you do these exercises with the rationale why we are suggesting that. And then you select and you enter the session. And most of the sessions were built to last about 5 minutes. And there are different kind of implementations, testimonials, videos, whiteboard, quizzes, etc. I also had a slide with a really nice video showing a session that didn't work, but I do have a link for the toolkit if anyone is interested in seeing these videos. From the user testing that we did, the whiteboards, which is those animation videos explaining some of the information, was the implementation that most users prefer during the user testing, and also the testimonials. And we had testimonies for different gender and ages also. So combined with this theoretical and this content of the toolkit, we also included the technologies, as I mentioned, so the Fitbit ARIA scale and the Fitbit activity trackers. And it's one of the challenges that I'm going to address, but it's really hard to incorporate in a research project a commercial product like Fitbit, and I will explain why after. What we did in the toolkit, because we wanted users to access our web app instead of going to the Fitbit app, as here is where we have all the content, what we did was have, this is in Portuguese, it's one of the versions, so everything was translated for 3 languages. So what we did was to have exactly the same tiles that you have on the Fitbit app with exactly the same information, so that users, and in real time this is synchronized, so users could have access to that information here and didn't need to go to the Fitbit app. Of course, the design is not the same as Fitbit, but until now that doesn't seem to be a problem for the users. So let's see how it works once the trial is finished. So this is just one example of the step style that we have, and one of the things that we added is that some activities like goal setting, action plan, coping plan are in the tiles. So the user can select their action plans just below the step style, for example. I enter, I see my graph, and then below I have, this is my goal for today or for this week, and then I do the action plan, and the action plan is always available, and I can change whenever I want to change. And the same thing for the coping plans. And we realized from the user testing that it was a really good approach for the users, because it's much easier just to do it on the tile than having to go to different areas. It's also interesting that for users that were already using Fitbit and other apps before entering the know-how, one of the things that they mentioned also in the user testing was that having this kind of goal setting and coping plan options in the tiles was really useful and really interesting for them because they missed that from other apps. So in the development of the know-how toolkit, we first developed the first version of the toolkit and conducted a feasibility study and user testing. We had, I think it was 10 participants in each country, and in Denmark we had more participants, 15 or 20. And then we refined and translated to the 3 languages, and then we did the pilot testing. The trial is ongoing. Until now we have 250 participants, and so far most people is using the web app. They are accessing the web app. They are doing the weekly sessions, different pace of course, but a lot of people are following the weekly sessions recommendation, and the same for waiting regularly. So just to conclude with some challenges. Trying to use theory and key mechanisms of action in this kind of digital tools when evidence is still limited was one of our main challenges. So we have a lot from research, but not specific for weight loss maintenance. And this was one of our main difficulties. And also, when we are selecting techniques related with emotion regulation or related with motivation, we don't have enough taxonomies or classifications to choose these techniques. So they are not classified in the same way as the behavior change techniques are classified, and we had to go through a lot of previous interventions to identify this. The same as I mentioned before, we don't have research looking at the link between techniques and digital modes of delivery for weight management or for weight loss maintenance. So it's kind of a guess, and talking with users and talking with colleagues at developing digital interventions, asking, what do you think it's better, a video or a text, a quiz or something else? And this makes it really, really difficult. The other is the engaging features. We are still building models on engagement with digital tools and digital toolkits, and we need more work in terms of understanding what are the features that will lead to a better engagement of the user so that we can use them in our research. And just to finalize, this one that I think is really important is how can we integrate Fitbit and other real-world apps in our research? And there are a lot of possibilities and positive aspects of doing it. At the same time, Fitbit changes, or I'm just using this as an example, changes their features almost every day. There are new things happening every day. And we are doing classic randomized controlled trials that are very strict in terms of the content. And sometimes Fitbit includes features or blogs or new activities that actually contradict or duplicate what we are doing. And this makes it really hard, so I think we also need to consider other kind of trials and study designs and other ways of testing digital interventions. And I'm done. If you want to know more about the project, you can just go to our website.